Okay, here's another one. Somebody help us. He's got a whiteboard program. Please, please help us. Bill is killing us with this friggin' whiteboard program. Oh, shut up. You'll love it. Okay, so here's what we got. We're going to talk today about COPD. And what we're going to do is we're going to differentiate between the two major types of COPD, and that is chronic bronchitis and emphysema. Now, I know this sounds really exciting, doesn't it? Wow, that A doesn't really look like an A. There's Bill's Perfectionist coming out. Oh, there we go. Chronic bronchitis and emphysema. Those are the things that we're going to talk about today. Okay, so what does COPD stand for? COPD stands for chronic obstructive pulmonary disease, or some people even say disorder. Whatever, disease. Chronic obstructive pulmonary disease. And how did these people get this way? That's the question. How do they get chronic bronchitis and emphysema? Generally, we would say it's either from life choices or it's from some sort of environmental factor. Patients usually don't just wake up one day and they're like, I have chronic bronchitis. Yeah, not so much. Generally, what happens is, over time, over years of abuse of their lungs, either through smoking or, they worked in a factory or something like that. My grandmother actually had emphysema, and she worked in a chocolate factory. Yeah, she breathed in chocolate dust. Now, granted, she also smoked like a chimney. Let's see if I can draw a cigarette. Can I draw a cigarette? Ooh, I don't know if I could. You know what? I'm afraid that if I draw this cigarette, it's going to look like a penis or something like that. But, you get the idea. So, Grandma smoked. Grandma smoked. So Grandma smoked for a really, really long time and developed emphysema, along with the fact that she worked in a chocolate factory and breathed in chocolate dust. So what I'm going to do is I'm actually going to break these down each on their own, and we're going to talk about them. So let's talk first about emphysema. 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 So one of the problems with the main problem, the main physiological problem with emphysema is that originally these people had really nice springy alveoli, right? Their alveoli were really nice and springy, and they were brand new, and the new car smell hadn't worn off yet, and all that kind of good stuff. And they were able to breathe out and breathe in and breathe out and breathe in. Remember, that's the essentials of life. And or at least that's what yoga tells me. And so they breathe out, they breathe in, they're perfectly fine. It's all great, yay, it's wonderful. But over time, what happens is they have done damage to the lung tissue. And now the alveoli have all started to break down, and in some cases, you get alveolar breakdown between the alveolar walls themselves, and you get these small alveoli that basically become these ridiculously huge alveoli. And you think, well, wait a minute, that's kind of okay because there's more surface area for gas exchange. No. The problem is that a lot of these areas are damaged and diseased, and so there's a decrease in the actual area that's available for good gas exchange, and that's why this happened. So there's not a lot of area for good gas exchange. So Grandma has, funky lung, and so what happens is we get O2 in, right? O2, no problem. O2, there it is. It comes in because Grandma can take a nice deep breath in. She can get that O2 in, but the problem that she has is getting the CO2 out. Grandma's big problem is that she has a problem getting CO2 out. She can breathe the O2 in. She has a whole lot of problem getting CO2 out. And so that's why these patients generally become barrel-chested, right? You've seen these relatively skinny people walking along with these big barrel chests, and that's because they are air trapping. Equals air trapping. So that's what's happening. These people are getting really barrel chested, and they're air trapping. They're air trapping all of this, just regular air into their alveoli there. And because the alveoli are all diseased and they're not able to contract the way that they used to, and they're just nasty alveoli. Grandma's got funky lung. Then you can't get the CO2 really out. Some of the CO2 actually just kind of sits in there and just kind of like, hey man, what's up? The CO2 just kind of sits in there and it doesn't want to leave, okay? It's the squatter of the lung. It doesn't want to leave. So, yeah, grandma gets really old, big and barrel chested, and, she really has some problems getting CO2 out. So this is why they say with your COPD patients, you want to go with a lower flow O2. Or just no O2 at all. That's always a possibility as well. If they are having a problem breathing, right, and you put their end-tidal CO2 on, and that looks, their end-tidal CO2, we'll talk about that later because we haven't talked about the actual graphs yet, but their end-tidal CO2 doesn't look good, let's put it that way, and their O2 looks okay. It's like 93 maybe, their SpO2. Let's say their SpO2 is like 93%, right? So if we've got a situation like that, low flow O2 is probably your best choice. You really don't need to put these patients on high flow O2. It's really unnecessary. Now, what if you come up and their SpO2 is a true 78%, right? So your patient really does have a low SpO2. And you can tell because they're having trouble breathing, they look really tired, they're cyanotic, all that kind of stuff. You look at that and you go, I'm just going to give them low flow too because, that's what Bill says to do. No, 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 no. Give these patients O2, it's fine. It's okay. All right. Now, what you don't want to do is you don't want to over-oxygenate these patients for more than 24 hours. Well, if you're transporting for more than 24 hours, you need to figure out what in the heck is going on. The other option is to use a Venturi mask. A Venturi mask, and we'll talk more about that in the coming days. Probably when I get back from Florida, we'll talk more about the Venturi mask and how that could be beneficial to our COPD patients. But the real takeaway from this, guys, if your patient is having trouble breathing, give them O2. Give them O2. It is okay to give them O2. It is even okay to give them high flow O2. It's all right if they really need O2. If you're walking along and you're like, well, everybody gets high flow O2 in my truck, so this guy with 93%, he gets high flow O2 too. No, that's a bad choice as well, okay? And the reason being is that these patients live on their hypoxic drive. They live on the fact that they have a higher CO2 and a relatively normal O2. But what's important is they really are based on the idea that CO2 is the main driver of their respiratory system. So if you go in there and you start washing out CO2 or you start causing major problems for them, again, long term, most of the time in the back of the truck when we have these patients, most of the time we're not going to cause them to go into respiratory failure simply because we put higher flow O2 on them, okay? There are some things we'll talk about in emphysema that are no-nos, okay? I hate it when I mess up my M like that. E-M-P-H-Y-S-E-M-A. Emphysema. Yeah. Looking back, look at that. See, I spelled it right there. I was nice and clean, and then I come over here and I'm like, well, emphysema. Emphysema. All right. So let's talk about some of the signs and symptoms of our patients who are having an emphysema problem. Let's start off with lung sounds, right? Their lung sounds are usually wheezy. I guess you'd put it wheezy, or would it be IE? I don't know. I don't know the grammar rule here, but wheezy. They're kind of wheezy patients. Usually it's dry. Usually dry. You're not going to generally hear a whole lot of junk in their lungs, but you'll hear some wheeziness and usually dry. And so most of the time these patients, they're not coughing up sputum or anything like that, right? You'll see very little, if any. You see little, if any, sputum, okay? Not a big deal. Little, if any, sputum for these patients. Now, blood pressure, usually elevated, and that makes sense if you're having difficulty breathing, but it could also be because they have some other comorbid factors. So they could be looking at something like maybe they have hypertension, maybe they have heart disease, which is always a good possibility because these are patients that usually have developed this because of, some sort of poor living or something like that, right? So lung sounds, there you go, wheezy and dry, sputum little if any, blood pressure usually elevated, hypertension is a good possibility, they have some comorbid, these are their comorbid factors. Heart rate, like I said in the CHF one, if you watched that first, and it's up to you, whatever one you wanted to watch first is fine. Like I said in the CHF one, usually heart rate in most of the patients that are having trouble with their respiratory illness will be elevated, and I think that's kind of a given. Once again, if the heart rate is down, I am not happy because that tells me that my patient is potentially decompensating. And if my patient is decompensating, that means they could be dying, and that's not what I want for my patients in the back of my truck, right? If you remember anything, I guess, out of this lecture, dying, it's not what we want for our patients in the back of our truck. Agreed. Okay, so let's move on here. Skin temp and condition. What do you think in these emphysema patients? Skin temp and condition. Think about this. They're trapping O2. So are they going to be cyanotic generally? No, they're usually not cyanotic. These patients are usually, they usually look normal or maybe slightly flushed. Maybe slightly flushed. Okay, normal or flushed. But here's where things can get a little bit important too, is that they are dry. These patients are usually pretty darn dry, and they're usually relatively skinny, okay? So they usually have a nice pinkness to them because they're O2 trapping, or they could be kind of flushed even in that red, and they're dry. And these are the patients that, in the history of EMS, we've always called the pink puffers. And that's usually because they're doing a lot of pursed lips breathing, Right, so they got that pursed lips breathing going on, they're puffing, their skin is relatively pink, looks relatively normal, maybe a little flushed, so that's generally your pink puffer. We already said barrel-chested, so they got that barrel chest. They're an emphysemic, right? They're emphysemic patients, so all of their alveoli have been broken up and they look horrible. Grandma's got the funky lung. Anyway, emphyshysema, emphysema. Bill's always got to make sure he spells that one to spell it right. All right, so treatment. Let's talk treatment for our emphysema patients. All right, I got a great idea. Here's my great idea. CPAP. Yeah, CPAP works for everybody, doesn't it? You think that's a good idea? Should we put CPAP on this patient? Some of you might be saying no right now. Some of you are yelling at the screen no. Some of you are saying, yeah, you said it, so, you're like, okay. No, double no, triple no, quadruple no, absolutely not, unless you want to explode their lungs. If you want to, blow those poor little diseased alveoli into oblivion, then fine, okay, go ahead with your CPAP. But that's a bad choice, okay? Remember, their little alveoli are no longer little alveoli. They're generally big and diseased, and they're air trapping and all that kind of great stuff. So what do you think happens if I put pressure, if I take some pressure and I put pressure on this here alveoli? What do you think is going to happen? Boom! I'm going to blow the lung, okay? So absolutely not. CPAP, absolutely, absolutely not. No way, not using it, bad idea. All right, so albuterol is a very good treatment possibility for these patients, especially if I'm seeing this on their end-tidal CO2, so kind of a shark fin waveform on their end-tidal CO2. then yeah, albuterol is a great choice for these patients. Atrovent will work too. Atrovent will work too. Atrovent will usually work if we're talking about some sort of a parasympathetic issue. So if they are developing, some gooiness in the lung or something like that, then yeah, emphysema, they could develop that. Then yeah, I think that's fine. Atrovent is a good choice. And even if they're not developing a lot of nastiness in the lung, Atrovent is not going to cause too much of a problem for these emphysema patients. So a lot of people just start off with a duoneb and see how well it works. Again, I have no real problem for that. I think Solu-Medrol is a possible choice. In terms of Solu-Medrol, if I'm talking about maybe some inflammatory process in there that's helping to make their emphysema worse today, then yeah, I think Solu-Medrol is a great choice. And that's really going to be based on your patient's history and what you're seeing and what is going on with your patient, right? And what's actually causing those issues. So, you're going to have to do a lot of history taking to determine whether or not your Solu-Medrol is going to be effective. Giving Solu-Medrol is absolutely fine idea. I think it's great. Go ahead and give the Solu-Medrol 125 milligrams. And again, you're not going to see that reaction to that right here, right now, but the patient will feel it in the future. And so that's what's really, really important. So albuterol, Atrovent, Solu-Medrol, but most importantly, no CPAP. Avoid CPAP. Completely avoid CPAP. These patients, if they're really having trouble breathing, O2. You just give them O2, and that could help as well if it's simply a breathing issue. Even though they are air trappers, who knows what could be going on today. Again, taking a good history, you might find out. But who knows what could be going on today that would make things worse for this patient. So yeah, that's going with just O2 is a perfectly good choice. And really, it's going to be about monitoring your patient and seeing how your patient reacts, okay? And then, of course, looking, and I can't stress this enough, looking at their end-tidal CO2. Look at their end-tidal CO2. The problem with things like chronic obstructive pulmonary disease is that the damage has been done. Okay, the damage has been done, and really these patients are just living with that damage. And that's just the way it is. And, you're going to have to treat them as best you can. That's really what you've got. So let's move on and talk about chronic bronchitis. Chronic bronchitis. Ooh, this is nasty. This is what I think of when I think of the person with the quintessential smoker's cough. You've probably all heard it. Maybe somebody in your family was like a chronic smoker or something like that. And then they're coughing up all of that stuff, and it's all gooey and nasty, right? And it's usually like a yellowy color or a green color, or, maybe it looks a little something like this. It's just nasty. It's really nasty, disgusting stuff. And the thing about it is it's very sticky, okay? Now, chronic bronchitis, the interesting thing that's going on behind this is in those airways, we have all of these little hairs, these little itty-bitty hairs, these little guys, and they're called cilia. All those little hairs. And obviously they're not spaced that far apart. But anyway, so there are all these little hairs in there, and those are called cilia. And those cilia act as sort of an elevator. They push all of that stuff up through the bronchial tubes, over into that pit of acid over here, which I can't draw, but that's your stomach. That's a terrible stomach. That looks like a stomach that was like hit by a car or something. My stomach was hit by a car. God, I can't draw. It's awful. Anyway, so chronic bronchitis, generally what happens is all of that mucus moves up over, goes into that pit of acid called the stomach over there. Well, the problem is with chronic bronchitis patients, they've damaged their cilia, and all of that junk is just sitting there in the airway. Ew. Yuck. Okay? It just sits there in the airway, like spackle. Just sits in their airways, and they'll try to cough it up, and that's why they get the sound like a cat with a hairball, you know what I mean? Anyway, so the other thing about it is it's very sticky. If you took this gooey mess and you stuck it onto a 4x4 and you put it against a wall, okay, it would stay there. It's gross. It's absolutely gross. Don't do that. Don't do it. I know what you're thinking, Ricky. Don't do it. You too, Garrett, or anybody else. It doesn't matter. Don't do it. It's gross. Okay, it'll stick to the wall. Yeah, but don't try it. And it's gross. It's thick. And you might even see little like little black specks in it like this. Some of the tar, some of the leftovers. There's even the possibility to see a little bit of maybe a little bit of blood tinging in it or something like that. Maybe there's some infectious properties and some. You get it. It looks like a really that actually kind of looks like a cookie. A really gross cookie. But anyway, sorry to ruin cookies for you. Hope nobody's eating right now. Anyway, chronic bronchitis, gooey, nasty mess stuck in those airways, okay? And so what we usually see out of these patients, let's talk about lung sounds. First of all, it's what I like to call the wet, dry lung sounds, right? The wet, dry lung sounds. Now everybody's thinking, wait, what? So this is where we talk about the term rhonchi. Or some people say rhonchi or whatever you want to call it, but rhonchi. Rhonchi. So here's the issue with your congestive heart failure, or excuse me, your chronic bronchitis patients versus your congestive heart failure patients. Chronic bronchitis patients are coughing up this really thick, gooey, nasty mess. Your CHF patients are usually coughing up more of a watery type mess. And so in CHF patients, we have these little tiny itty bitty bubbles. Remember we saw that on the CHF one, or if you haven't watched the CHF one, you'll see it when you watch the CHF one. Well, the difference with this is that you're actually sort of breathing up this nasty, viscous, kind of spackly stuff. And so it makes a much sort of deeper resonant sound. So when you hear crackles, it's kind of these high-pitched little like bubbles in water. But when you're listening to chronic bronchitis over here, listening to this stuff sounds kind of, I don't know, like blowing bubbles in motor oil. Also not a good idea. Don't do that. You might accidentally swallow some more motor oil, but don't do that. Anyway, so it sounds like blowing bubbles in motor oil. It's really thick, viscous stuff. And so it's really hard for the patients to clear this stuff out. And so that's why every morning they sort of cough this stuff up, and it's just really gross sounding. I won't do it again, just in case any of you are eating trying to watch this. So lung sounds, the wet, dry sound, it's a wet sound, but it's a thick sound, so it almost sounds a little drier than that typical sort of congestive heart failure patient over here with the small bubbles. All right, so lung sounds. There we talked about lung sounds. Let's talk about blood pressure. These patients are usually chronically hypertensive. They generally have high blood pressure because they have comorbid factors. They have heart disease, or they have any myriad of things to kind of go along with all of this breathing issue that they have. So we add in the fact that just all of these nasty things that they've done throughout their life or whatever it may be, kind of gross. But they have high blood pressure. They were smokers a lot, and they like my grandmother worked in a chocolate factory. So she developed emphysema. Some of these patients will develop bronchitis. All right, so blood pressure. So let's talk about heart rate. Well, duh. Their heart rate is generally elevated, and as I've said in all of the other ones, and I'll say it in this one too, just in case you're watching this one first, a decrease in your heart rate, that is bad because your patient is generally decompensating. And I don't mean just a simple decrease. If I bring their heart rate down from the 130s to the 90s, I don't go, oh my God, he's decompensating, oh, help. No, he's getting better. But when your patient is in the 140s, excuse me, and then all of the sudden they start dipping and dipping and dipping and dipping, and you start to notice they're becoming bradycardic, that is when we have a serious issue. Okay? That patient is decompensating. So, let's talk about their skin temp and condition. Skin. So in terms of their skin temp and condition, these people are usually kind of puffy. Okay, or you could say bloated. They're bloated or they're puffy, okay? And usually they're cyanotic. Now, a term I want you to look up is I want you to look up finger clubbing or clubbed fingers, okay? I want you to look that up and I want you to actually see what clubbed fingers looks like. This is very possible with these chronic bronchitis and even some of these emphysema patients. But your chronic bronchitis patients, they are generally cyanotic, and so we always used to call them in the annals of emergency medicine, we would call them blue bloaters. Blue bloaters, right? So this is where your pink puffers and your blue bloaters comes from. Well, these patients are hypoxic. There's no doubt about it. They are hypoxic. So giving them oxygen is okay, but again, they are trapping some CO2, and so they are living on that hypoxic drive. Okay, so CO2, they're still trapping some of that CO2 trap. There's still some trapped CO2, so they are still living on a hypoxic drive. So these are also patients that I usually go with low flow O2. Low flow O2. Again, if your patient is having difficulty breathing, they are blue, right? And you're like, well, I can't give you O2 because you have chronic obstructive pulmonary disease. Then you're doing it wrong. Okay? You can give them oxygen. Absolutely, you can give them oxygen. The chances of you knocking out their hypoxic drive in the 15 to 20 minutes that we have them in the back of the truck are pretty much nil, guys. So go ahead, give them oxygen. So if they are hypoxic, give O2, and I can't stress that enough. If they're hypoxic, go ahead, give them O2. You can give them O2. Keep an eye on them, obviously. If you're able to just give low flow O2, great. But if you have to go with high flow O2, go ahead and go with the high flow O2. The hypoxic drive, we're not going to knock that out just in the back of our truck. There is the possibility that if we keep them on that high flow O2 for 24 hours or something like that, yes, we could knock out their hypoxic drive, and that's terrible, and we don't want to do that. But if they're hypoxic, give them O2, please. Okay, so let's talk about treatment. Treatment for our chronic bronchitis patients. Okay, albuterol, good choice. Albuterol is a fine choice. Okay, 2.5 milligrams. Fine choice there, no problem. Atrovent. So I want to put a star by Atrovent. And the reason I want to put a star by Atrovent, actually I put 2 stars by Atrovent, is because I do have some concerns that if I dry up those secretions, that I now cause those secretions to be much drier and much harder to clear out of the lungs. So I'm not saying Atrovent is contraindicated. I'm just saying be careful. Be careful, monitor your patient, watch your patient. Usually if you're giving them Atrovent or Duoneb or albuterol Atrovent or something like that, you're giving them that medication, they're getting some humidified air, so it actually may counteract itself, but I am still a little concerned about giving a lot of Atrovent with these patients. So I'm usually a little bit more likely to go ×2 on my albuterol before I then go to Atrovent. But again, it's up to you. You are a practitioner. So it really is kind of your choice as to whether or not you think that's going to be right for your patient. Monitor your patient, look at your patient, make decisions based on what you think is going to be best for your patient. Now, for chronic bronchitis, Solumedrol. I like Solumedrol. Solumedrol is definitely a good choice here. Okay, with our chronic bronchitis patients, they're almost like chronically inflamed. So giving them some anti-inflammatory is not necessarily a bad idea. Okay, give them a little something to help with that inflammation. That's usually a pretty good idea for your chronic bronchitis patients. No real problems there. All right. You can probably think of some other treatments for your chronic bronchitis patients. One of the treatments that that I actually like quite a bit is I give them humidified oxygen. If I give them O2, I usually try to humidify the O2, and it will help to sort of break up some of those secretions. Now, the nasty side effect of this is that they'll cough them up, and then, you've got spackle that's just coming out of their lungs. Yay, gross, with all these little nasty little dots in there. Of course, we said maybe even a little bit of blood in there, or the gross cookie, right? The gross cookie, you get it. It's a cookie with sprinkles, okay? And so yeah, you have these patients that are coughing that stuff up, okay, and that's a little gross, but better that than leaving it just down, sticking in their lungs there, okay? If it comes down to it, obviously, with your emphysema patients or your chronic bronchitis patients, if it comes down the road that you actually need to intubate these patients, well, then that's what you have to do. You have to intubate these patients. And that's kind of going to be up to you as the medic to make that decision of when that's best for your patient. So looking back, chronic bronchitis, some of our better treatments here. Albuterol, Atrovent, we want to be a little careful with, but we can definitely give. Not saying that it's contraindicated, but we just want to be a little careful with it. I'll usually have 2 albuterols in a patient before I'll consider an Atrovent on them. And then Solumeterol 125 and some humidified O2 is always a nice thing for those patients. Obviously, if they're having any other problems, any comorbid factors, we try to treat those as best as possible. And usually these patients, right, these COPD patients, generally they bring along a lot of baggage. Their problem is usually not just respiratory, it's everything. They have heart problems, they have blood pressure problems, they could have diabetes, they have all of these comorbid factors that are just making the situation worse. And so you really have to get a good history on your patients, and you really have to do a lot of thinking about what might be best for your patient in that particular situation. So for now, that's COPD. I'll probably have a little bit more to talk about when I come back from Florida, but there's the basics, guys. Hope you enjoyed.